Hello everyone. Hi. It's live, right? Hello. Hello everyone. Hi. Good evening, everyone. Sorry for the delay. So for the 5-minute delay. Now let's. What I basically wanted to discuss and what we wanted to do with the help of this session, we have already had 2-3 episodes of this the art of solving MCQs. But the one thing that I wanted to discuss, just prior to NEET PG, what is the purpose of the session? See, as far as solving MCQs is concerned, it's not magic. If you know the answer, you know the answer. You don't know the answer, don't know the answer. But what I want to tell you is that if you're in the exam, you keep your calm, you don't get panicked, you read all the 4 options, you read the question carefully, and you use your common sense. You simply use your common sense, a little bit of intuition, and a little bit of luck. And you want to call it luck, you want to call it grace of God, you want to call it blessings. A little bit of common sense, a little bit of intuition, a little bit of luck can what actually result in, let's say your basal level is you're getting 130 corrects, you're getting 130, 135 corrects. They might just get pushed to 140 corrects. So right now you might be having a rank of 30,000, it might become 20,000 on the exam day. Your 140 corrects might become 145, 147 corrects, the 20,000 rank might become a 10,000 rank, right? And you might be having a 145, 150 corrects currently, and it might become 160 corrects, some 10 questions, 10 questions here and there, that's about it. 7-10 questions which you probably don't know the answer, you are making silly mistakes. You just think logically, you use common sense and a little bit of luck, and you can actually have that 5 to 10,000 jump in the rank. You can have that 5 to 10,000 jump in the rank, of 15,000 rank can easily become a 7-8,000 rank, and then can suddenly open up a plethora of options. Right, that's what we want. Right? That small last push. There are 2 things which cause the last minute push. One, which I always talk about, the last week revision. Very important. Last week revision ensures that all the volatile stuff is at the surface so that you're able to attempt the questions. From the INI-CET this time, like everyone, as far as INI-CET is concerned, everyone will say, this is the review of INI-CET if you're given the INI-CET. Sir, padha sab tha. The questions were not something which were out of the blue. All of them were previous year topics. All of them were the questions which we have solved in our GTs, which we have done as far as MCQ solving or the Q banks are concerned. It was just tricky. Now, why does it feel tricky? It feels tricky because on the exam day, you're not able to eliminate 2 options. On the exam day, you are getting confused between 2 options. Hence, it is feeling tricky. To get over that, you need to do the last 7-day revision to ensure that you don't feel tricked or you don't feel confused between 2 options. Right? And the second thing is simple, a common sense and intuition. A little bit common sense, a little bit intuition, a little bit of jumping over, taking a calculative risk, and you might get 5 or 10 extra corrects. And that's what we are going to discuss in this session. I'll be discussing around 8 to 10 MCQs. All these MCQs had around 40 to 50% corrects. As far as the, the Marrow mock was concerned, all these MCQs had around 40-50% corrects. So basically 50% of you were getting it correct, 50% of you were getting it wrong. Those who were getting it wrong, if on the exam day you get these 5 to 10 extra questions correct, your rank suddenly improves by 5,000, 10,000. Alright, and I really hope Supreme Court gives a verdict in your favor that it's a single NEET PG shift. It's not 2-shift exam. Everyone understands how unfair it is to have 2 shifts exam, and I really hope and I pray with the with whatever I have that the Supreme Court actually listens to us, listens to the doctors, and gives a gives a verdict in favor of a single NEET PG shift. All right. Now, let's begin this particular session. So this one, let's start with this question. A patient presented with anemia. Decreased haptoglobin, elevated LDH. They have given you a peripheral smear. Which of the following, first of all, see the question carefully. Which of the following is not a differential? They're not asking the differential diagnosis. They're not asking the diagnosis. They're asking which of the following can not be a differential diagnosis. So let's see what they have given. They have given anemia. They have given what? They have given increased serum LDH. What does increased serum LDH tell you? That there is going to be burst of the RBCs. That's why LDH is going outside. That's why there is going to be increased LDH. Increased LDH signifies what? There is going to be Hemolysis. Increased LDH signifies what? That there is hemolysis. That's what increased LDH means. And then they have given you this peripheral smear. What does this peripheral smear show? This peripheral smear is showing you schistocytes. This peripheral smear is showing you schistocytes. All right. Now, even if you did not understand these are schistocytes, let's simply, even if you are able to get to increase LDH means hemolysis, let's just restrict ourselves to that. Increase LDH means hemolysis. It is a hemolytic anemia. Some form of hemolytic anemia. Let's see the options. HELP. HELP syndrome. HELP. What is the full form of HELP? We know HELP is what? HELP is hemolysis, elevated liver enzymes, low platelets. It is low platelets. So hemolysis is there. So HELP syndrome can be a differential, and HELP syndrome occurs where? HELP syndrome occurs in preeclampsia. HELP syndrome occurs in preeclampsia. Right? Then you have thrombotic thrombocytopenic purpura, TTP. TTP is an example of microangiopathic hemolytic anemia. It's an example of what? MAHA. It's an example of MAHA. It has a pentad of microangiopathic hemolytic anemia, thrombocytopenia, decreased platelets, neurological dysfunction, fever, and AKI. These are the 5 things that occur in TTP. We know that this is what happens in TTP. Now, between malignant hypertension and Fanconi, think logically. HELP syndrome occurs where? In preeclampsia. In preeclampsia, there is what? There is hypertension. If there is excessive hypertension, that will cause kidney damage. We know kidney damage is a part of thrombotic. So even if you are able to make that connection of malignant hypertension either with HELP syndrome or with AKI, you will be able to understand that even malignant hypertension can result in this form of hemolysis. Malignant hypertension can result in kidney damage, and it can result in microangiopathic hemolytic anemia, resulting in these schistocytes. It can result in microangiopathic hemolytic anemia. It's a differential. So even if you did not know, even if you use a little bit of intuition, your HELP syndrome hai. HELP syndrome occurs in preeclampsia. Preeclampsia is hypertension. In fact, preeclampsia is a form of malignant hypertension where there is end organ damage. Even if you're able to think on that logical line, you should be able to see that, okay, hypertension, malignant hypertension should cause this kind of picture. Hypertension can cause preeclampsia. Preeclampsia will result in HELP syndrome. Even if you're able to get to this line, you are, okay, this causes, and this causes. So the only option left which will not be a differential diagnosis, which will not cause hemolysis, will be what? It will be Fanconi. This will be the correct answer. Fanconi anemia becomes the correct answer. And Fanconi anemia, remember, Fanconi anemia is a hypoproliferative anemia. It's a bone marrow failure syndrome. So even if you, let's say, if you know it's a bone marrow failure syndrome, it's obviously a very easy question. Even if you don't know if it's a bone marrow failure syndrome, the other 3 options you can rule out. One, HELP is related to preeclampsia, related to hypertension, A is hypertension, and TTP we know it causes hemolysis. TTP we know has hemolysis. So this way we can rule out and get to the answer that is going to be Fanconi anemia. Fanconi anemia will not have hemolytic anemia. It's bone marrow failure. Let's come to the next question. This is even easier question to get to the answer. Easier question to get to the answer. A 57-year-old male has come with severe headache. Now he is unresponsive to analgesia. MRI brain is shown. MRI brain में तुम्हें क्या दिख रहा है? What are you seeing in an MRI brain? Can you see there is a huge lesion here? Iska matlab, that means it is some form of malignancy. That means it's some form. You can see a tumor. This is the tumor. Now you don't know which kind of tumor. You are not radiologist. Even I am not a radiologist. We don't know which tumor this is. Let's see the options. The 4 options are glioblastoma, meningioma, glioblastoma, meningioma. So it basically means either it is a glioblastoma multiforme or it is a meningioma. It is either a glioblastoma multiforme or it is meningioma. That examiner himself has given you 50-50. That to examiner already has given you 50-50. Now think logically. If it is a meningioma, if it is a malignant tumor which is coming from meninges, meningioma, then will it occur right in the center? Or will it occur somewhere here? Or will it occur somewhere here? If it is coming from the meninges, it's going to occur near to the meninges. Why will it occur right in the middle? So you can rule out meningioma. This cannot be meningioma. Now you are left with glioblastoma multiforme. From which cells it is arising? And the answer is very simple. It's astrocytes. It arises from astrocytes. In fact, astrocytes grade 4 is glioblastoma. Astrocytoma grade 4 is glioblastoma. Microglial cells are nothing but, we all know microglial cells are nothing but macrophages. These are nothing but what? They are macrophages. From macrophages, malignant tumor you don't expect. Even if it's a malignant tumor, let's say macrophages cause malignant, they can cause HLH, they can cause multiple things, but that will be a hematolymphoid malignancy. That will not be a solid tumor like this. So even from that, even if you know microglial cells are macrophages, obviously that's not the answer. So the answer is going to be glioblastoma multiforme, occurring because of astrocytes. So simple. On the exam day, you just have to, let's be very honest. On the exam day, people who got a really good rank also are not confident in more than 120 or 130 questions. For 120, 130 questions, they are very sure. Answer aata hai. Rest 60 questions, they go logically. They get a 50% strike rate and they get 160 correct. That's how it happens. That's how it actually happens. All right. So this is even if you don't know meningioma, glioblastoma, how they do grid logically, simple logical thinking, agar meningioma hoga, तो meninges से निकलेगा ना, तो meninges तो यहाँ पर हैं. These are the meninges, not right in the middle. So this has to be glioblastoma, and glioblastoma arises from astrocytes. Microglial cells तो macrophages होते हैं. They are macrophages, right? Now, coming to this one, the image below shows the logo of which national program? Now इसमें ध्यान से देखो. What do you see in the image? You see a baby. Most importantly, you see only a baby. You see only a baby. There is no mother. Is there any mother here? You are seeing only a baby. Only a baby. Now let's look at the options. Lakshya is related to what? It is related to labor. It is related to labor room quality improvement. It is related to labor room quality improvement. Labor room means mother. Janani Shishu Suraksha Karyakram. Janani Shishu Suraksha Karyakram. Mother and child. Janani Shishu. Janani in Hindi means mother. So there is mother. And PM SMA is what? Pradhan Mantri Matritva Yojana. Again, it is related to mother only. This is also related to mother. So in all these three options, you have mother. But even if you don't know the logo is giving you only a baby. So the only option which has only baby is India Newborn Action Plan. That is the answer. Option B will be 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 the answer. That's how you're going to get the. All right. I'll just show you 1 second. Just give me a moment. See this. This is the logo for Lakshya. This is the logo for Lakshya. Can you see a mother and a baby? Because it's labor room. So mother, baby, both are there. Plus Lakshya, Lakshya has Q in it. So that's why they have made a Q out of it. All right. Let me show you the logo for JSSK. This is JSSK logo. This is the logo for JSSK. Janani Shishu Suraksha Karyakram. Again, this is the Janani. And this is the Shishu. In both the cases, mother is there. In both the cases, mother is there. So this is how you can rule out. In this, even if you didn't know the logo, you could see it is only a baby. Rest all three had mothers in them. Cannot be there. You take a educated guess that it's going to be India Newborn Action Plan. And it's going to be option B will be the answer. That's how you take an educated guess, a calculated guess, and a calculated risk. Let's come to the next question. Let's come to the next question. A patient with convulsions. A patient with convulsions has been brought to the emergency department. He is poisoned with what? He's poisoned with strychnine. He's poisoned with what? He's poisoned with strychnine. He's poisoned with strychnine. Which of the following is incorrect about the management? So even if you don't know what strychnine is, forget about, let's say, strychnine. Thoda sa yaar, halka sa little bit of lateral thinking. Do a little bit of lateral thinking. You know, strychnine, alkaline. It means strychnine will be a alkaline compound. It means strychnine will be a alkaline compound. Same for, it is valid for nicotine. Nicotine is also alkaline compound. Strychnine is also alkaline compound. They have ene in the end. They have ene in the end. Anything which has amine, ene, amine is amino acid. Amino means alkaline in nature. Anything which has amine in the end. All these things will be what? They will be alkaline in nature. If they are alkaline in nature, if you want to get them out of the body, you should do what? You should do urine acidification. You should do what? You should do urine. This makes sense, right? If the compound is acidic, you do urine alkalinization. If the compound is basic, you do urine acidification. That's what we do. Now, this is a alkaline compound. This basically is a alkaline compound. If it's an alkaline compound, you need to do acidification, not alkalinization. So this option, automatically option A becomes incorrect. Option A, it automatically becomes what? It becomes incorrect. And hence option A is the answer. So even if you did not know everything else about strychnine, simply strychnine, okay, imine, alkaline है ये तो. Nicotine alkaline होता है, strychnine alkaline होता है, amine alkaline होता है. तो alkaline को alkalinization से थोड़ी ना करोगे. You need acidification. You would need acidification. The other concept, for example, there are certain drugs, for drugs like, you know, acetyl salicylic acid. Like, for example, this is a NEET PG question. This is a PYQ. This is a PYQ as far as NEET PG is concerned. And they love testing this concept. So they asked in aspirin. Aspirin, what is the full form of aspirin? Aspirin is what? Acetyl salicylic acid. It is what? It is acetyl salicylic acid. Acid hai. So that's why in this particular case, we do what? We do alkalinization of urine. We do alkalinization of urine. Same goes for methotrexate. Same goes for methotrexate. Methotrexate is also an acid. Methotrexate is also an acid. Methotrexate is the analog of folic acid. Again an acid. Again we do what? We do alkalinization. So that's how. A little bit of prior knowledge and you can get to the answer. A little bit of prior knowledge and a little bit of logical thinking, you can get to the answer. Okay, let's see this question. Let's see this question. This is a very simple question. A 60-year-old male, alcoholic liver disease, you are suspecting hepatorenal syndrome. You are suspecting what? Hepatorenal syndrome. Which of the following parameters is considered most appropriate while making the diagnosis and a progressive rise? A progressive rise in which of the following? Okay. So either there should be a rise in something which kidneys are not able to do or liver is not able to do. If liver is not able to do something, ALT, AST should rise. ALT, AST should rise if liver is not doing its function. Albumin should fall. So albumin will fall. In any liver disease, albumin falls. Will it rise? A progressive, they're asking progressive. So automatically albumin is ruled out. Albumin actually will fall in any hepatic problem. Right? Now, yeah, urea and blood urea nitrogen, they mean what? They are essentially one and the same thing. If urea increases, the blood urea nitrogen increases. If urea increases, the blood urea nitrogen increases. So how will you make a choice whether it is BUN or urea? They mean essentially, they are essentially the same. They're essentially the same. The one thing which is very characteristic of your kidney is what? Creatinine. In fact, AKI, as far as AKI is concerned, AKI staging, we do with the help of what? We do it with the help of creatinine levels. AKI staging we do with the help of creatinine levels, not the urea levels, not the BUN levels. So in hepatorenal syndrome, kidneys are failing. Again, we'll have rise in creatinine only. That will be the most characteristic finding. So again, the answer here is going to be very simple. It's going to be creatinine. Logical thinking. Hepatorenal syndrome, kidneys are failing, creatinine will rise, urea also will rise. But for AKI, which is more specific, which is the one which we use in AKI definition, we use creatinine. So here also, if you have to make a guess, creatinine is a better answer as compared to taking a guess of blood urea nitrogen or urea, where blood urea nitrogen and urea are essentially one and the same thing only. That's how you can get to the answer. Just using your prior knowledge, making a logical conclusion and taking a calculative guess, you can get to the answer. You can get to the answer. Let's see this question. Again, a very simple question. Not a simple question, but even if you know some things, you can get to the answer. Match the following tumor markers with the respective tumor. Let's see the first one. First is what? Neuron-specific enolase. Neuron-specific enolase. Now, one is matched either with E, or it is matched with D, So basically what the examiner is telling you, that I want you to know whether one is small cell lung cancer, whether it is small cell lung cancer or whether one is bladder cancer. And one is what? One is neuron specific anoles. One is what? One is neuron specific anoles. Now, just one fact you need to remember. Small cell lung cancer is a neuroendocrine tumor. Small cell lung cancer is what? Small cell lung cancer is in fact a neuroendocrine tumor. It's a small round blue cell tumor like neuroblastoma, retinoblastoma, Ewing sarcoma. All these belong to small round blue cell tumors. All small round blue cell tumors are positive for neuron specific anoles, NSC. They're positive for, the name itself is telling neuron specific anoles. Small cell lung cancer is a neuroendocrine tumor. So why will it be bladder cancer? So one automatically becomes with D. It automatically becomes with D. So immediately we know that option A and option C will be incorrect. Option C will be, it will be incorrect. Okay. 2 easy, 2 easy. It's same for both. Now we come to 3 and 4. That is what we're going to determine. Now, 3, CA199. CA199, they're saying with, in B, it's saying with breast cancer or it is with pancreatic cancer. It's with pancreatic cancer. Or 4 with, they are saying with 4, they are saying either it is with ovarian cancer or it is with breast cancer. Now, this a little bit of prior knowledge, but you would remember CA199 is much more specific for pancreatic cancer. This is going to be this, right? CA19 is to pancreatic cancer. It's related to pancreatic cancer. So answer will be option D. Answer will be option D. Answer will be option D. So simple. That's how you can eliminate and then at least make a guess where you at least have 50% chance of getting it correct. Even if you knew one, even if you could rule out one thing, that yeah, small cell lung cancer is a neuroendocrine tumor, so it should be positive for neuron specific anoles, not bladder cancer. Not bladder cancer, right? Not bladder cancer. Then we come to identify the anomaly seen in this ultrasound. अब यार ये देखो, तुमने, even if you have not done radiology at all, you can make out something, right? This is a baby, this is the nose, this is the heart, and this is where the stomach should be. And then here it is. Now, where there should be the abdomen, something is coming out. Something is coming out from abdomen. So this is what? This is going to be abdominal wall defect. This is going to be abdominal wall defect. You can easily make out this is the head, this is the chest, this is the chest, and this is the abdomen. Something is coming out from where? From the abdomen. It's going to be abdominal wall defect. Amongst this, which is an abdominal wall defect? Only gastrocystis is abdominal wall defect. So even if you have not done radiology of gastrocystis, don't get suddenly scared what this kind of radiological image is. Keep calm. See the image. You can easily see that the contents are protruding out from abdomen. They're not coming from chest. If they were coming from chest, it would have an ectopia cordis. If it would have coming from, the brain, or it's coming from, the head, then it would have an encephalocele. It could have a neural tube defects. So even if you don't know the answer, you can just directly get there. It's going to be what? It's going to be gastrocystis. Simply by seeing what? Simply by seeing that there is content protrusion from the abdomen and there is only one abdominal wall defect amongst the 4 options. That is your gastrocystis. That is your gastrocystis. That is your gastrocystis. Now, look at this question. Which of the following patients will be diagnosed with severe acute malnutrition? Now, SAM ki definition is something which they love to ask. This you have to remember. This, I just wanted to discuss SAM ki definition because I'm a pediatrician. So I thought that let me at least discuss the definition of SAM before you go for the exam. What is the definition of SAM? What is the definition of SAM? So SAM is defined as any one of the following. A, when the weight for length is less than minus 3 standard deviation. Okay. Or when the mid upper arm circumference is less than 11.5 centimeter, but this is used only from 6 months to 5 years. It is used only from 6 months to 5 years. Or there is bipedal nutritional edema, or there is visible severe wasting. Or there is visible severe wasting.
The reason, these two things are very obvious. These are age independent criterias. When you want to diagnose SAM, you don't want to use an age dependent criteria. That's why weight for age is never used for SAM. Weight for age can be low in both acute and chronic malnutrition. That's why SAM is never defined using weight for age. Okay. Why is there bipedal nutritional edema? This is to ensure that Kwashiorkor child is always classified as SAM. See, a Kwashiorkor child will have water retention, so weight can become normal. The mid-upper arm circumference, because of that water retention, can become normal. We'll call a Kwashiorkor child as normal. That is not, we don't want to do that. That's why any child who has nutritional edema, bipedal nutritional edema, you will have to call that child as having SAM. If there is visible severe wasting, this denotes what? The child is having marasmus. Child is having what? Child is having marasmus. So obviously you have to call that child as SAM. Let's look at the options now. Which of the following will be diagnosed with severe? Now, a 9-month-old child with MUAC of 12. No. What is the cutoff? Cutoff is 11.5 centimeter. So you cannot diagnose it with SAM. A 7-month-old with weight for age. Remember, when the weight for age is less than -2, it is called underweight. It is not called acute malnutrition because weight for age can be low in both acute and chronic malnutrition. That's why when the weight for age is less than -2 standard deviation, child is called underweight. When the weight for age is less than -3 standard deviation, child is called severely underweight, not acutely malnourished. The terminology for weight for age is underweight, not acute malnutrition. Child will be called as what? Child will be called severely underweight. So can you diagnose this child as having SAM? Again, no. A 6-month-old with bilateral pedal edema, yes, you can. This child you can. A 5-month-old, no. For a 5-month-old, the mid-upper arm circumference has no value. You use it from 6 months to 5 years. The only patient which can be diagnosed with severe acute malnutrition is option C. It's going to be option C. It's going to be option C. Okay. All right. Last thing that we discuss. Again, sometimes even if you don't know a lot of things, even from the prior knowledge, you can get to the answer. Now, this thing required the knowledge of something called as RPI, Reticulocyte Proliferation Index. But even if you don't know about RPI, still you can get to the answer. Let me show you how. They're telling you that there is a 35-year-old female with pallor. Her hemoglobin is 7. Her hematocrit is 21%. Okay. And her reticulocyte count is 3%. Which of the following is the most likely interpretation? See, whenever there is a hemolytic anemia, this is a very logical thing. Whenever there is hemolysis, then as a result, there is going to be a marrow response. The blood is getting destroyed in the body. Marrow is going to respond. This is going to result in increase in marrow proliferation. And this will cause increase in the retic count. This will cause an increase in retic count. Fair point. Whenever there is marrow failure, that marrow itself is not working. For example, in case of vitamin B12, in case of anemia, for example, in case of leukemias, for example, let's say there is leukemia, let's say there is Fanconi anemia, the bone marrow failure syndrome. In this case, there is going to be a decrease in marrow proliferation and there will be decrease in retic count. There will be a decrease in retic count. This is a simple concept. This is a simple. That's why retic count is called poor man's bone marrow. That even without doing a bone marrow, you can get to know whether bone marrow will be hyperproliferative or hypoproliferative, right? Now let's see. There they have given you a hematocrit of 21%, hemoglobin of 7. So they are telling you there is anemia. They've given you a reticulocyte count of 3%. First, we have to do what? This thing you must be remembering, that you have to do something called as corrected reticulocyte count. You have to do something called as CRC. Corrected reticulocyte count is given as hemoglobin. Sorry, it is given as the absolute reticulocyte count into hematocrit, patient's hematocrit by normal hematocrit. So in this particular case, it will be 3% into 21 by 45. So this will be around 1.5. So this will be around 1.5%. This will be around 1.5%. Now tell me, if you have a hemoglobin of 7, what is a normal reticulocyte count? It is 1 to 2%. Normal reticulocyte count is anyways 1 to 2%. Do you expect a 1.5% count for a hemoglobin of 7? Marrow should be hyperplastic. If marrow is not hyperplastic, it means there is inadequate response. If there is inadequate response, it means it is hypoproliferative anemia. It can never be a hemolytic anemia. So first, if there is adequate first of all, there is an inadequate marrow response suggestive of hyperproliferative anemia. Because we can see the corrected reticulocyte count is only 1.5%, which is normal. It should be more. So even if you don't know the concept, the actual concept requires something called as reticulocyte proliferation index, which you can see in the explanation. I'm not going to go into that. Even if you did not know the concept, even if you knew the concept of simple corrected reticulocyte count, at this time the reticulocyte count is just 1.5%, and normal itself is 1 to 2%. You is 1 to 2%. With a hemoglobin of 7, it should at least be 8. The corrected reticulocyte count should at least be 4, 5, 6%. Should be higher. It is not higher. It means the marrow is not responding. Marrow is not responding means there is inadequate marrow response. Suggestive of what? Suggestive. Can it be suggestive of hemolytic anemia? No, in hemolytic anemia there is adequate marrow response. There is always high marrow response. It is inadequate marrow response suggestive of a hypoproliferative anemia. So this is, whenever you have, this was a very, all right. This is what I basically wanted to tell you. This is basically, the concept goes something on, this part has been asked multiple times, so I'm writing down the formula. Corrected retic count is given as the retic percentage that you have into the patient's hematocrit divided by normal hematocrit. So in this particular case, it will be 3% into 21 divided by 45. Normal hematocrit is around 45. So this will be around 1 by 2. In fact, 1 by more than 1 by 2, 1 by 2.5 or something. So it will become 1.5%. I will not even go into RPI. RPI will want you to divide this further by 2. RPI wants you to further divide this by 2. Let's not even go into that. You can learn about it later. But even if you did not know about RPI, from this itself, you could get to the answer, right? That 1.5% is not normal, right? If you're having a hemoglobin of 7, you want the reticulocyte to increase to show the marrow response. Here it is not increasing. So it is inadequate response. Why is it inadequate? Because the marrow itself is not responding. There is hypoproliferative anemia. Marrow itself is hypoproliferative, right? So this is the way I wanted to basically teach you. 10 questions I discussed. There's full possibility you might have answered 3, 4 or maybe 5 incorrect. I have given my exam 7 years ago, 7 or 8 years, 7 years ago, right? I didn't want to answer to any of this, right? But when I saw the question, I was like, ये तो logic से solve हो जाएगा. Even if you don't know the actual answer, ये logic से solve हो जाएगा. That is the entire point. On the exam day, keep cool. I know it is easier said than done, but before going to the exam, please remember your parents, remember your God, Gayatri Mantra or whichever, you want to remember, do the puja, the Quran ka pata, whatever it is. Do that. Keep calm. Take thoda deep breaths. See all the questions properly with a calm mind. And then attempt. Dekhna. Logically, you will be able to solve so many questions. Agar 10 question bhi from your current upar ho gaye, badh gayi na rank. I'm not saying there's going to be some magic. Let's be very honest. Someone who has 100 MCQs correct today, on the exam day, it's not going to happen that you will suddenly get 150 MCQs correct. No, that doesn't happen. Par, if you have 130 correct, on the exam day, 140 to 145 to ho hi sakta hai. If you have 130 correct today, on the exam day, 140 to 145 to ho hi sakta hai. 100 to 50 in the next 2 weeks, not possible. Let's be very honest. Let's not give you hopium. Let's not give you Delulu is the only Salulu. No, right? But a logical increase. You do your last 1 week revision properly. You have 5 questions correct because of that. You reduce your 5 silly mistakes and you solve 5 questions with a little bit of logic, little bit of luck, little bit of confidence. And who knows, 130 becomes 145. The 20,000 rank becomes a top sub 10,000 rank. 5,000 rank becomes a, 2,000, 1,000 rank. That's it. On the, this is something which I really want to tell every one of you. All right. This is a very important question. What kind of question should be left unattended? If it's a fact-based question, which you have absolutely zero idea about, you cannot rule out one option also. If you cannot rule out even one option, then don't attempt that question. If you cannot even rule out one option, and it's a fact-based question. For example, there was a question I once asked in AIMS, which aquaporin is present in lens? Aquaporin 1, 2, 3, 4. Something similar. I don't remember the exact question. Which aquaporin is present in the cataractus lens, in a cataract lens? Something on those lines. Aquaporin 1, 2, 3, 4. Something like that. Now, this is a proper fact-based question. And how do you get to know whether it's 1, 2, 3, 4? There is nothing you can do. There is no way you can rule out. There literally is a 25% chance that you will get this correct. So leave such questions. Leave such questions. These are the questions you have to leave. If you have absolutely zero idea, फिर तो कैसे करोगे? But yeah, questions like these, right? For example, like this one. In these questions, if you can, even if you don't have not done radiology, that's fine. Like, ठीक है, revise नहीं हुई. Radiology was not, you were not able to revise radiology. That's fine. But you can see, right? Easily see कि भाई यहाँ से आ रहा है. It's going to be abdominal wall defect, marked gastrocysts, right? Right. The only thing that I really want to tell you guys right now is that I'll share the PDF if you want. I don't know why you want the PDF for this particular thing. But what I basically just wanted to convey, try to get those 5 to 10 extra questions correct. Try to get 5 to 10 extra questions correct. And that's about it. You would have outperformed yourself. 10 extra questions correct. Immediately your rank will become half of what it is currently. You're having a 20,000 rank, that becomes 10,000, 10,000 becomes 5,000, 5,000 becomes 2,500. 10 questions correct. 5 questions from the last 10-day revision, last 7-day revision, so that you don't make silly mistakes. And 5 questions, a logical thinking, little bit of praying to God, and you're there. See, there's no difference between a top 100 rank or someone who got rank 1. Knowledge is same. On that day, the rank 1 got 2-3 extra tukkas correct. Right? It is not that rank 1 was the most brilliant person on that exam day. On that day, he was more lucky. So trust your luck a bit for 5 questions. Thoda logical thinking for 5 questions. And 2-3 questions, silly mistakes nahi karni. You are at 10 extra questions correct. That's it. Right? Okay. So this is, yes, my one-shot PDF as far as pediatrics is concerned is enough. One-shot PDF as far as pediatrics is concerned is enough. All right. I'm not demotivating anyone who's at 100 or 110 corrects. But I'll be very honest that if you feel that you are at 100 corrects for past 6 months, let's say your consistent GT scores are at 100 corrects for the past 6 months, and you believe that on the exam day you will get 160 corrects, then you have to be honest, not with me, and it's not demotivation. It's just looking into the mirror. If you're at someone who has at 100 corrects, obviously it can increase to 120 to 130 corrects if you have a good exam day. Nobody's going to deny that. But if you feel that from 100 corrects, you'll suddenly go to 160 corrects and you'll get rank 1, then that is Delulu is the only Salulu. Right? We have to be honest to ourselves. Alright, if you're not honest to yourselves, then there's no point. फिर पढ़ भी क्यों रहे हो? What's the point of studying for 6 months? Last के 3 दिन बैठ के exam दो और exam निकाल लो. It's that easy an exam then. Right? If someone is feeling it is demotivating, then it's simply because you take a hard look in the mirror. You are the ones who are going to give the exam. Please put in the efforts. You can definitely improve by 15 to 20 MCQs. That's what I told you right now. 5 MCQs, less silly mistakes. 5 MCQs, luck. 5 MCQs, logical thinking. You can definitely improve by 15 to 20 MCQs in the last 2 weeks. No doubt about that. Absolutely no doubt about that. But to think that you'll go from 100 corrects directly to 150 corrects. All right. If it's a hard paper, see, if it's an easy or moderate paper, attempt 190-ish. If it's a hard paper, attempt 170-ish. Don't go below 160. Don't go below 160. That's a blunder. Don't go below 160. Okay? All right. All right. And there was one person who said, King sir, mere na 130 aa rahe the. In INI, I got 110 correct. For this particular question, like let's say you were consistently in the 120 to 140 correct range. Let's say you were someone who was in the 120 to 140 correct range, but in the INI में तुम्हारे let's say 100 to 110 आए हैं. तो first of all ये INI है, not NEET PG. Picture अभी बाकी है मेरे दोस्त. Two very different exams. INI is heavy on anatomy. 20 questions in anatomy. And NEET PG में 7 questions of anatomy. Anatomy is such a volatile subject, you might have gotten most of them wrong, or might not have attempted them. That's why you in normal GTs, you were getting 120 to 140. So don't be disheartened by INI score. Don't at all get disheartened by INI score. Focus on that last 7 to 10 day revision. Focus on that last 7 to 10 day revision. Ensure that ये 120, 140 तुम्हारे बने on the actual exam day, and you get that 15 question bonus. Logic, little bit of luck, little bit of help from God. That's it. Okay. Okay. अगर यहाँ पे आपके 120 to 140 correct आ रहे थे in the GTs, you were touching 120, 130, 140. In INI you got 100 and 110. Then I would say, please don't take that INI score to your heart. Your actual score is this. On the exam day in INI, you probably faltered. Don't repeat that mistake in NEET PG. Learn from whatever mistakes were there as far as INI was concerned. Learn from your mistakes as far as INI is concerned. Ki haan, us din maybe I could not rule out between two options. I had not revised anatomy properly. I had not revised biochemistry properly. Then revise those things properly. You know, these were the things that I left out. This was a not in the question which I did not read. And ensure that you get that 130, 140 correct in the actual exam day as far as NEET PG is concerned. That would be my advice. This doesn't define you. What happens in NEET PG defines you. And that's why giving INI was so important. So that you actually get to know that actual exam that NEET PG is not sacrificed. NEET PG is not sacrificed. All right. You can easily improve your score by 15 to 20. 15 से 20 बढ़ सकता है, 50 नहीं बढ़ेगा. This is what, you know, I'll give you what is logical and what is actually possible. 15 to 20 MCQs of your regular GT scores can actually improve on exam day. A little bit of logical thinking, little bit of MCQ solving, little bit of luck. Not 50 MCQs. That's what I'm trying to tell you. Okay, don't be in that delusion. वो मत करो. You will hurt yourself only. हाँ, 15 से 20 definitely बढ़ सकता है. उसके लिए मेहनत करो. उसके लिए work hard. उसके लिए ensure that the next 20, 15, 20 days, you don't take a single moment off. Do that. You owe it to yourself. Don't have that regret that in these 20 days, I wasted 1 minute watching an Instagram reel or going on Twitter or anything like that. You owe it to yourself. You owe it to your parents, or you owe it to yourself most importantly. है ना, इन 15-20 दिन लगा दो and get those 15-20 MCQs correct यार, है ना. ठीक है, चलो अब let's go, right? ठीक है, चलो let's go. बाकी जो डिस्कशन है we'll do it at some other point. Thank you. चलो, good night.